Yeah, hi all. This is the supplementary lecture, basically a lab lecture, supplementing the lab that was going to be held on April 7th. It's April 8th now. Sorry, I was a bit under the weather and really wasn't able to have spend a whole day last on Monday. But here we go. This is where I'm just basically picking up where we left off in lecture and just continuing on. And we're going to go into digestive thereafter. I loaded. I will load, if they're not already there, digestive PowerPoints for us. So you can pick up with that as well. I'll get that taken care of tomorrow, either right around the time of lecture or immediately before lecture. But let's finish up with this first PowerPoint, which is here, which is lung diseases. So there's not a lot left in this. So we're dealing with, and really, these chronic obstructive pulmonary diseases basically means there's something blocking the road. So emphysema, again, emphysema involves aspects of thickening of the conductive, thickening and difficulty with air passing through the conducting division, and then air getting trapped in the respiratory division. So it's got features of both, and the worst possible word that we can when we're dealing with patients or medical or for you and your family is right there, irreversible. Words like reversible are great. Words like curable are unbelievable, and treatable are really good. Irreversible, very bad word. Okay. Common features: 80% of the patients are smokers. Let's be clear. The number one problem. I realize that cigarette smoking and smoking in general has gone down significantly. I mean, I think the jury is still out on vaping. I mean, to a certain extent, we learn more about those as time passes if there's long-term complications. But all that being aside, fortunately, at least there's a lot less smokers, but there are still plenty of smokers, and in different cultures, there's more smokers than there are now at present. Uh, it's been a very progressively uh, improved stance on smoking. Look at buildings, look at college campuses, look at hospital campuses, and things like that. All of that. So effectively, the characterization is dyspnea, and dyspnea would be a better way to pronounce it because the P is not necessarily silent, for air hunger, coughing, frequent infections, uh, hypoventilation accompanied by. And so, what happens when you're hypoventilating, you're retaining carbon dioxide. That leads to respiratory acidosis, lack of oxygen because there's more, the carbon dioxide and the oxygen are interchangeable. The more carbon dioxide you have floating around inside the bloodstream and in the system, the less oxygen you're going to have proportionally. Emphysema is the part of it involves permanent enlargement of the alveoli, and remember talking about the alveolar walls, lack of elasticity, and here are the other things. Breathing is supposed to be effortless. So the accessory muscles are so much more needed, and it's fatiguing. I mean, that's 10 to 15% is a lot of extra energy to expend that you now don't have the ability to use it elsewhere. The trapped air, which is the definition of emphysema with hyperinflation. The diaphragm remains flatter, so and the chest is more barrel chested or expanded, and because of that, now you have a lack. Again, the normal starting point is a dome diaphragm and relaxed muscles of the external intercostals. They're already, and this is muscle 101 physiology. You have less available muscle to contract. You have less available actin and myosin just because they're already in a significant. It's going to be more than that. That 80. Remember that 80 to 120. I mean, you've already contracted this a whole lot more, so you don't have a lot to go. And obviously, there's going to be, because remember, blood vessels surround it. You're going to have problems with capillaries, and effectively, this is something. In the old days, we called it cor pulmonale, which technically meant lung heart, but really what it leads to is right heart failure. And because of this problem with the lungs, it's very, very difficult for the right side of your heart and the right ventricle to effectively pump blood for oxygenation. And it's going to struggle to do that. And we're going to see the right side as the part side is going to fail. Yes, there's some hereditary factors that are involved in this. Bronchitis, chronic, again, goes along with smoking, excessive mucus. I can't even begin to tell you how disgusting it was for me when I'm constantly coughing up stuff. The lower respiratory passageways become inflamed. I mean, I was characterized. I remember my first wife telling me how much I wheezed, and I wheezed constantly when we slept. So all of those obstructions are there, difficulty with gas exchange, again, the frequent infections, and again, smoking. And again, even for non smokers or secondhand smokers, and environmental pollutants play a role as well. So, and this is where we talk about this pink puffers and blue bloaters. It's interesting. Pink puffers, and it has to do with their body type. So, we'll do the pink puffers first. Thin, okay, large amount of energy, breathing, near normal blood gases, so the skin color is normal. So it's kind of, and we see that more with a typical emphysema patient who is just having a difficult time because there's been so much lung destruction that they really have very little vital capacity that's there. And then body type goes with it. And blue bloaters, you're looking at, this would be me. Patient usually stocky, nice word for being, you know, round as a shape. Cyanosis is due to hypoxia, so the skin color takes on the bluish hue. And all the usual culprits, bronchodilators, steroids, oxygen. I don't know enough about lung volume reduction surgery. I guess it must be. And the difficulty with it, again, oxygen in excessive amounts is toxic, so you have to be really very careful with that. I mean, it can be to some extent a two-edged sword. You wouldn't think of that with oxygen, but these folks, because their ability to deal with almost any abnormalities, and this is just another one, toxic derivatives of oxygen that are there. And you can see some of these, you know, yes, the hereditary, there's A1 alpha 1 antitrypsin deficiency, breakdown of elastin in lung tissues, continual inflammation, chronic bronchitis, emphysema, and both of these end up with those obstructions of airways, both larger and even smaller airways, perhaps more so smaller than larger, difficulties with ventilation, respiratory acidosis. Asthma, we classify it in this regard as a chronic obstructive pulmonary disease, but it has more acute episodes, and we do have acute episodes, and everybody knows somebody with them. Unfortunately, they go for looks, and again, we have improved treatments and bronchodilators and inhalers today than we did years ago. But coughing, difficulty, breathing. If you've seen somebody with an acute asthma attack, it's very frightening. Okay, inflammation of the airways is part of that leads to those bronchospasms. It's immunological in nature because of interleukins and IgE and inflammatory cells that are there. And over time, that airway thickens and it really increases the effect. So it have to be addressed and hopefully address the underlying cause. And I mean, you can try to desensitize people. You can do allergens exposures. There's different things. When you're talking about TB, you're talking about something that's very destructive. And now you're really reducing the viable areas in the lung for exchange. And long term, this is the classic. It's chronic diseases like cancer and tuberculosis, which is has very much a similar presentation to lung cancer, and sometimes a challenging diagnosis to determine which is which. In the old days, we have more sophisticated techniques now. Fever, night sweats. Night sweats are something that people get when there's something going on inside that's bad. I mean, so typically it's a fancy word called cachexia. It's almost like people are withering away, weight loss, coughing up blood. And it's interesting. In pneumonia, we get blood tinged sputum. Sometimes you get bloody sputum. This is a little bit different. It's almost like a mixture. Though it's blood and sputum together. So yeah, I mean, it's not pleasant to think about. But when we have rusty sputum, you think about it has to do with partial hemolysis, typically Streptococcus pneumonia was the most common agent for bacterial pneumonia. Klebsiella pneumonia, the most common in the hospital, is almost a pure, like a cherry red kind of sputum because it has so much damage to the cells. Where Mycobacterium tuberculosis, TB is almost like a swirl of like a reddish and green swirl. Long courses of antibiotics. You have to take multiple antibiotics, one antibiotic, one, two. We have a variety of different things. I don't know how much background you got in micro. With TB, very difficult to treat. And lung cancer. Leading cause of cancer deaths in North America, 90% because of smoking. Enough said. Three different types. Adenocarcinoma. This is, and we definitely see this in the periphery of the lungs, glandular structures, the alveoli cells themselves are part of it. This is the largest container. When we start seeing it on regular X-ray, I know the technology has changed today, but on traditional X-ray, they had what were called coin lesions. So they were almost like circular, and maybe the size of like a dime, a nickel or a dime on the side. And when you saw that almost etched in calcium, it was like, oh boy. Squamous cell arises in the bronchiole. Remember, the bronchi begin to change as it begin. You have the pseudostratified ciliated columnar, and you start to get down to squamous cells. Now you're getting into some of the linings of the bronchial epithelium, and then the worst of these, and you can see it's I hate to say not uncommon, but least common. Small cell or oat cell carcinoma, those are those lymphocyte-like cells, those scavenger cells that run around, originate in the primary bronchi, subsequently metastasize. So when the cancer begins in those areas, that's a very bad diagnosis. Very poor survival rate. It's all about detection to have a chance. You have to get it from it before metastases has occurred. I do not know. Now they used to do full lung removals. Now they're doing it because they realize if you can get the segment before you have obvious spread. So they do segmentals, not just lobe removals, but segment removals. Okay. Uh, I mean, and the usual culprits, radiation, chemo. There's no magic right now for them. And radiation chemotherapy are not great. Other things that we don't, it's interesting. There's so much controversy. I'm even a controversy. There's so much inconsistency in the effectiveness and generating some of the problems with these sleep apnea devices. It may be a problem I have. I don't know. I've never bothered to go for the wake up. I know a lot of people have sleep apnea. It's relatively common. They have difficulty breathing when they sleep. People don't know about it. You have to do those sleeping studies, and it's not easy to to try to sleep when people are observing you and you're hooked up to machines. I can't imagine it is. Maybe some people can do it better than I couldn't even think about doing it. And excessive daytime sleepiness. I wake up plenty of times during the middle of the night, but not up to 30 times per hour. You know, okay. And the most common type, some problem, some degree of obstruction. You can see the pharyngeal muscles can lead to it. That's interesting in and of itself. Sometimes, when you talk about central, this has to do with respiratory centers. And these are some of the problems. And unfortunately, I haven't experienced this with being overly tired and driving and things like that. I don't have increased problems with chronic illnesses, fortunately, because of these things. So I don't think it's a classic example, but I mean, you can imagine these can be very, very severe. And now these CPAP devices are different. Uh, you see all sorts of advertisements about them. I think it's a matter of finding one that works for you. What little I know about them, and that's very little. And that really concludes this chapter on respiratory, as you can see here. And for that, already done, I'm going to go right to digestive. So we take that away, and I go over here to the digestive area for you to look at, which I have these PowerPoints. And these are ones we use for anatomy. And so you should be going back and taking a look at them. This is the first one. I'm going to try to get through the first one, but because I don't want to revisit the anatomy. I want to focus mostly on the physiology. There's not a lot of anatomy to be concerned with until we really get to the stomach and small intestine. The stomach and small intestine have the vast majority of relevant anatomy, a little bit in the large intestine. That's about it when we talk about digestive physiology. So I wanted to get a head start on this so we can continue on with this over the next couple of days. And with the respiratory done, now I'll be able to, I already have the exam on board. We'll figure out when I can release it to you, and we'll all go from there. Whatever. Let's see. So let me get back here and get my little cursor and voila. Digestion. Going back what it is. So really it consists of these parts. Ingestion, taking food in, digestion, breaking it down, absorption, breaking it down. Digestion doesn't mean it enters your system. It's still in the alimentary canal, effectively a hollow tube that runs through your body. And until it is absorbed by way of the alimentary canal, either directly or indirectly into the bloodstream, either it goes into the bloodstream or it goes into the lymphatics, that's absorption. Now it's on the inside. It doesn't mean it can't be damaged because toxins within the digested food irritating the lining, something as common as being lactose intolerant. All of those are things that can produce problems during the digestive phase. But now we look at absorption and obviously excretion of what is indigestible or waste products or things along those lines. So those are the four major ones. Again, to reiterate, ingestion, digestion, absorption, and often we use those terms interchangeably, and they are not. And that's important from a test perspective to be aware of that, and elimination, if you want to make it sort of global in that term. So effectively, this is anatomically, you might remember the system consists of the alimentary canal. Okay. I have a text, let me just tell them. I'll be right there. Should have my text dinger off so I wouldn't notice it. Okay. And so the alimentary canal is effectively a hollow tube. That's the way to frame it. That's the primary structure. Anything else, all the glandular structures, whether they're salivary glands, whether it's the liver, whether it's the pancreas, whether it's the gallbladder, are all accessory structures. So the primary structure, which is our gut, is the gastrointestinal alimentary canal or GI tract, whatever you want to call it. And again, it's a muscular tube that runs from your mouth to your anus. There's nothing magical about this. It does digestion, and I frame them as mechanical digestion, like chewing, and chemical digestion, like the aforementioned people who are lactose intolerant and don't have the enzyme. That's the chemical aspect of digestion. And then the absorption through the various linings that are there. And again, to reiterate the most important point about linings, when we get to the stomach, small intestine, large intestine, the lining is simple columnar with goblet cells. Again, columnar means goblet cells, means mucus. And it plays, and it's a really important aspect. And when we get to this, you're going to see your digestive system has a very interesting set of controls that are chemical controls and certainly pH, uh, hyperosmotic material, so the osmolarity of the material, the pH of the material, mechanics of things going through these tubes. All of those are really what trigger our digestions. Pretty interesting. And again, this is one I have, unfortunately, a lot of personal experience. Just to reiterate the point, I had not one, but two giant ulcer surgeries, 8 hours in duration, one in 1993 when I was, oh, get this, 42 years old, and one in 2000, not yet 50 years old. Two giant surgeries where I had to have half my stomach removed and have it rerouted by way of the jejunum. I had it done once and I had to have it done a second time. So understand that I have, unfortunately, too much personal experience with that. So there's not a lot to say about the mouth, and you'll be thankful again that I don't do teeth or anything about that. Okay. And there's a little bit, and there's not a lot to say about the throat because you already said it in respiratory. And again, in the esophagus, there's not a lot to say about the esophagus because basically it's a food tube. I mean, with the esophagus, there's nothing special about it, but I'm going to point out areas where digestion begins, and then we'll probably start promptly with starting to look at what happens when it gets from the esophagus into the stomach. That's the logical starting point, I think, for physiology. So I want to get the basics out of the way today. And you can see stomach, small intestine, large intestine, and finally, leading into the anus, rectum, and then the anus and out. Accessory structures. The tongue's not a big deal to me. It's I don't go crazy over it. We talked about taste buds. What does it do vis-a-vis the digestive process? It helps to compact the food a little bit, moisten the food, hold on to it because it's kind of roughened, and really facilitate chewing and swallowing more than anything else. The teeth, mechanical. And you're going to see when we talk about different aspects of digestion, the mouth is mostly mechanical digestion. Yes, it's the start of chemical digestion. They're going to have different terminology, but that's terminology that I use. When we get to the gallbladder, different. Okay. Gallbladder is all really is an important part of chemical digestion. It's interesting in its role, and you might remember my description to it. It's like an overflow tank for bile. It's non-essential tissue. And then the glands, like the salivary gland, liver, and pancreas, are all vital and important, and etc. And it's a good illustration anatomically. You've seen 1,000 of these. They all look the same. Nothing. We're not going to go over it. That was anatomy class. So ingestion, eating. Now, the other thing remind you of is the beauty of this system is it operates on its own. Things like sympathetic and parasympathetic system are I don't want to say overrides. They play a role, but they are not an essential role. Effectively, a lot of your digestion is done by the nervous system that is contained within it. We call it the enteric. It's part of, when we say enteric, it implies that it's part of the alimentary canal. And it has its own nerve system. So when sympathetic nerves or parasympathetic nerves either tell it to slow down or speed up, they're not essential. It's going to work anyway. Okay, it's got enough nerve supply that it can pretty well work on its own without a lot of helpers. So remember that and so a lot of these movements that occur when we talk about uh, the acts of peristalsis and segmentation, the way it's propelled, as you might remember doing it, you squeeze it and push it along, squeeze it and push it along, back and forth, squeeze it and push it along. Effectively, those are things it's going to do under almost any circumstances. So ingestion, the action of eating, propulsion, moving it from start to finish, if you will, from mouth toward the anus. Assisted, obviously, you have to swallow it, and that's mostly pharyngeal constrictors and some action of the tongue and some structures within the pharynx. Okay, that's about all that is. Peristalsis is the major means. The skeletal muscle, the voluntary skeletal muscle activity kind of ends about 2/3 of the way, one half to 2/3 of the way distally going down the esophagus. And at that point, skeletal muscle gives way to smooth muscle. That means involuntary. And that's where peristalsis takes over. And the muscles are arranged that way. And I'm going to review the interesting anatomy of how the muscles are constructed and there's 4 layers because we've talked about a lot of 3-layer stuff, remember? Bronchi and blood vessels, and we'll get to the urinary tract, which has 3 layers, all well and good. Okay, arteries and veins, the heart. What's interesting about we have a 4th layer. The reason we have a 4th layer is the internal lining. Okay, what we call the mucosa is so complex. It's got 3 layers of its own, and it has a 4th layer underneath it just to service it. It has its own, effectively, it's almost a specialized layer whose whole job is to take care of a lot of the functions of the other 3 of the triple layered, most internal or deep layer of the lining that we call the mucosa. Love that. So peristalsis, and you might recall the way the smooth muscle is arranged. It's arranged circularly around the lumen, circularly around the tissue that's lining the opening, which we call the lumen, lumen, and then another layer longitudinally. Now, sometimes we'll have an additional layer outside of it or inside of it, but consistently we have circular, deep, and longitudinal superficial, and that's the way those alternating waves of contraction and relaxation lead to this peristalsis, pushing it down, squeeze, push, squeeze, push, squeeze, push. And in certain areas, particularly the small and large intestine, because that's where the small intestines where effectively all absorption occurs. And then a lot of the processing and then moving it on certainly to the large intestine to facilitate excretion and bowel movements is, really to thoroughly get all of this back and forth mixes, so it's mechanical, some amount of propulsion, and there, because of the finalizing sort of the mechanical digestion is really where it facilitates absorption. So it's a very well organized, and we have a lot of it. And you might remember talking about anatomically, and given my situation where they had to remove some of it, we have a fair amount of spare parts that are in there. This is a good thing. Now, I call this mechanical digestion. They call it breakdown. Don't care. It includes segmentation. It includes peristalsis. It includes chewing and the stuff that we do with our tongue and our mouth and our teeth. All of that is mechanical breakdown. And the other big organ where you get mechanical breakdown is the stomach. It's a giant mixing bag. Remember, I framed it that way. And you can see the segmentation, local restriction of the intestine, it mixes food with digestive juices, all along. When we talk about chemical digestion, we begin catabolism or breakdown, utilizing certainly enzymes and, more important than anything else, water, because it's effectively, this is all hydrolysis. It's basically hydrolysis. This is a little different with fats, for sure, because we do have to break apart the fats into their components. But again, it's enzyme based, but still there's hydrolytic processes that are involved. Absorption is taking these fragments, as you will see, down to their smallest possible molecular structures that are organized. E.g., examples of this are proteins being broken down into amino acids and being absorbed. That's that whole crazy notion of, oh, I'm going to take creatine supplements because it's going to make me have more muscles. Don't work that way. We don't absorb creatine. It's a giant protein, can't get through. We absorb the amino acids. Those are the building blocks to make more muscles. Okay, I'll buy that. Okay, you add more building blocks. You have and do all the other good stuff, proper nutrition, otherwise exercise. All the good things that we know will help build more muscles. You'll build more muscles. Okay, and defecation, obviously, indigestible substances, and a variety of other waste products, and enough moisture and mucus and stuff to lubricate it to facilitate its passage. Okay, that kind of good stuff. And this is a neat chart that we looked at before, and you can look at again, all the different things they do in different areas, neatly color coded for your excitement. So here we get to it. Remember, review this anatomically. We're dealing with peritoneum, effectively starting once we get into the peritoneal cavity, once it pierces the diaphragm. Okay. We have standard parietal peritoneum on the wall, but the visceral peritoneum is interesting because it's not like a single membrane that surrounds the heart or surrounds the lung. It's unique, that membrane, because it surrounds the individual structures, and sometimes there's additional membrane going from other structures, like the connection of the liver to the stomach. So it's very interesting. It's almost like double folded. And inside the folds of that visceral peritoneum are blood vessels and nerves and lymphatics. And that's the blood supply that's very interesting. Okay, because remember, we're dealing with a hollow tube. Everything in our body is bilateral and symmetrical. Not. We only have one alimentary canal. You have one stomach. I mean, either oddball things where people have two stomachs, sure. Okay, but we have one stomach. We have one liver. We have one duodenum. We have one small intestine, one large intestine. Da, 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 da. So the visceral peritoneum, moist lining, simple squamous, we call it serosa, and that's the big one. It's the parietal peritoneum, and then the visceral peritoneum is a little bit different. And obviously, there's peritoneal cavity, there's fluid in there, and it's all about movement. What's unique about most structures in the body are pretty firmly attached: hearts and lungs and bladders and ureters, not digestive system. What's neat about that? It's got to be able to move. It's bad when it's not able to move. So there's limited areas, you might recall me talking about, where it's kind of tacked down, and typically areas where important things happen. And what happens is that effectively the visceral peritoneum, bigger pardon, the visceral peritoneum has been absorbed along with the parietal peritoneum into the posterior wall, and we have a great name for that. As sort of the lining, as sort of the parietal peritoneum kind of overgrows the area, we call it retroperitoneal, sort of the back wall, retro or behind. That's there. And so this double layer of visceral peritoneum has a great name. It's called the mesentery. Okay. And extends again from the wall around all those organs. As I said, blood vessels, lymphatics, some fat storage. It's not a big deal. Okay. And so we look at organs that are located within there, we call intraperitoneal, unless they're, again, it's on the back wall, you'll see the eye. So the retroperitoneal are posterior to the rest of the peritoneum. Again, sort of being reabsorbed and having the parietal peritoneum reform. And as you can see, look what's in a couple of areas of the large intestine, typically close to the flexures, if you remember, the hepatic and the splenic flexures, where the ascending goes to transverse, the transverse goes to descending. A great deal of the pancreas. Pancreas is absolutely vital, can't live without it. Super important, double duty, endocrine and exocrine gland. And the duodenum. And what's in the duodenum? The common bile duct, you might remember. Without that, you can't. Your digestive tract doesn't function. If that goes, the only way you can get nutrition into by way of the alimentary canal is it has to be effectively pre-digested and put in there. And that's something that I was looking at potentially post-operatively after the first surgery and the problems I had leading the second surgery and all those transfusions, et cetera, et cetera. And here's what I mean. So here, this visceral peritoneum is like the layers fuse, and there's the pathway for blood vessels and nerves. You can see now the ventral mesentery is a little bit different. This we're talking dorsal. The liver has ventral mesentery, and again, effectively there's additional layers, if you want to think of it this way, to attach. And here, where it's been reabsorbed, the mesentery, and then surrounded by the parietal peritoneum, we have retroperitoneal. And inflammation, you can go through all this stuff, and what happens, it's nasty. The biggest problem, not just from infection, but anytime you invade this area, even in surgery like I had, the biggest thing is this: peritoneal covering stick together. Okay. And the problem is, okay, it may localize infection, but the problem when peritoneal covering sticks together, a lot of times the organs that are supposed to be freely movable don't move. We have a great word for it because they adhere. We call them adhesions, and they're the bane of existence. They're the thing that general surgeons hate the most. And you have to be so careful, which is why my surgeon takes 8 hours to do those, because he doesn't want very meticulous surgery. He doesn't want any adhesions. Thankfully, I didn't have any. And so this is the whole idea of the tunics. You have a very specialized. Mucosa isn't just, oh, it's pseudostratified ciliated columnar, or just plain simple columnar. It's 3 different layers. You're going to see you're going to have the epithelial lining. You're going to have a specialized layer of muscle tissue. You're going to have another layer that lies under the epithelial area, as you will see very shortly. And you might remember from what we did before, the submucosa, which services the mucosa and contains some of the nerves so they work. So we have this enteric system, what we call the gut brain, so the gut works on its own. Then you're going to have the smooth muscles highlighted by that consistent circular around the lumen, and then external to the circular, we have longitudinal to facilitate peristalsis and to facilitate segmentation, and then the moist lining on the outside we call serosa. The difference again between serosa and adventitia, like around the esophagus, is a dry lining. It's not designed to move, it's designed to adhere to the surrounding tissues for support. And then the esophagus lying right behind the trachea and the continuation of the respiratory tract. So these are the layers. You might remember the mucosa, all the things. It's simple columnar. Columnar cells are busy cells. They can secrete, they can absorb, they can protect because of the things mentioned, because of the things they secrete. And the beauty of all these lining cells in the alimentary canal from the stomach, small intestine, large intestine, we replace them constantly. There's the most act, and you and I, and effectively, probably immediately, even before puberty, these are by far and away the most highly reproductive cells in the body. They're the most mitotic. Every 3 to 6 days, we get a complete new set. Even a little faster in the small intestine because those are the cells that are subjected to the most activity, the most digestion of a chemical basis, and the most absorption. It's just amazing. And because of that, they are just remarkable. And so even if a disease adheres to them, there's a great deal of protection. And there's a whole lot of safeguards that are associated with it as well. It's a major area, just like respiratory root disease. It has an epithelial lining, layer number one, right? Obviously, like any lining opening into the lumen or the hollow cavity. The lamina propria, the proper layer underneath the epithelium supporting it directly. Remember, epithelia are avascular. They have to get all their nourishment from the tissue underneath it. And then that meat muscularis mucosa, that layer of smooth muscle that has stretch receptors that effectively adapt themselves so they can maximally contact food that begins to pass through the lining, whether it's wherever it is located. Okay. So whether it's in the stomach, small intestine, or large intestine, I always, me, I like to think of it as though your gut is embracing your food. It likes it. So the lining simple columnar with goblet cells, and you can see in most of the tract, with the exception of the mouth and the esophagus, stratified squamous, non-keratinizing, as well as the anus. So the exit and entry points, no, but once you're away from them sufficiently far, simple columnar. Mucus, lubricates, all those kind of good things, and a lot, depending on the area, different enzymes and different hormones. The underlying luceralar connective tissue, again, all the nourishment needed. And remember, they're so highly mitotic, they need a lot. And as you can see, because this is where the defense comes in, we have all of this, talks about it before, mucosa associated lymphatic tissue, lymphoid follicles that defend against microbes, because we're not eating sterile food, everybody. Understand that. So another term we give to this is GALT, gut-associated lymphoid tissue, and that smooth muscle, they say local movements of the mucosa. There's the one you can see it before. It's very, very clear, okay, without going crazy about it. Here you can see the lining, and this is opening, for instance, they're showing you it to a gastric pit, which we'll probably get to tomorrow. A little bit, we went over before, but I'll do more of the physiological aspect of it. Here you can see those accumulated lymphoid tissues that are there in the submucosa, I beg your pardon, in the lamina propria. Effectively, it's a submucosa of its own. Here's the muscularis mucosa. Here's the true submucosa, where these gastric pits open into these gastric glands, more blood vessels and nerves and lymphatics that are designed to support all of these structures. And again, provide the local movements. You have to have a nervous system that plays a role into it. And that's part of what we see in here when they start to look about these intrinsic nerve plexus. You have one in the submucosa layer, and you have one that's associated myenteric, which is associated with the muscular layer. It's here. So again, you have the three layers of the mucosa, submucosas, the muscular externa, always first circular, then longitudinal. Again, sometimes variations, either internal to that or external to that. More common internal, particularly the stomach, and then the serosal lining on the outside. It's not very specific. Here's the submucosa, more areolar connective tissue, more blood and lymphatics. Again, the nerve plexus that's there. Okay, abundant amount of elastic tissue because they don't lose their shape. That's another thing I forgot to mention, but it's really important. And here, the externum for segmentation and peristalsis, also where the sphincters form, where it narrows, whether it's the cardiac sphincter or the pyloric sphincter, etc. And then the outermost serosa, you can see the difference adventitia in the esophagus until it gets into the peritoneal cavity, then serosa. Voila. Not worried about the circulation. Fancy name is splanchnic. We talked about that in anatomy. Basically, the celiac artery, the celiac trunk, which has the hepatic artery, the gastric, and the splenic, and the inferior, superior, and inferior mesenteric arteries. And again, don't forget that the venous circulation is unique. That hepatic portal circulation. Remember, it, 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 it's not bilateral and symmetrical. So the whole thing, and you saw where the liver was, with having its almost like own support system. If you remember that little diagram with the peritoneum that are there, all of the blood coming from the stomach and the small intestine, and some from the large intestine, are fed. They're collected from capillaries there. They're collected in the vein because that vein goes to a capillary network in the liver itself. We call it a portal. Portal means two veins that a vein, capillary bed, then a vein. Because veins usually go, capillary beds, veins go back to the heart. Not this one. It goes from a capillary bed in the digestive area to venules to veins to a capillary bed in the liver. That's the hepatic portal vein. Then from the capillaries in the liver, where after it's been processed, it's collected by venules into the hepatic vein and then into the inferior vena cava. You might remember that when we did that in anatomy and circulation. And again, the so-called gut brain, these nerves that basically extensively communicate with each other. And so, and that's the major nerve. So you can function without fight or flight when it slows it down, or when fight or flight goes away and the parasympathetic goes ramps back up and gets it like when you're asleep when it takes over. That's what you have to remember. And these are the two plexes, submucosal and myenteric, and a variety of reflexes. And I'm not going to go crazy about that stuff either. Okay. And all the key concepts: stretch receptors, osmolarity receptors, pH receptors. And then the fact that there's anything in there, substrates and end products of digestion, all of those play a role. But the big three are anything that goes in there, because the tubes collapse when there's nothing in there, almost squeeze tight. And once they stretch, immediately that starts the process. And then you have chemical sensors for osmolarity, and everything is pH controlled. The stomach is acidic pH, the small intestine is alkaline pH. Okay. Okay. And when stimulated, all of these things, movements, mixing, activating or slowing down the various secretions, which we call digestive juices, are part of it. So again, we have intrinsic controls and extrinsic controls. We'll go into the hormones. Oh, this is one of those unique systems where, I mean, cells, once the stomach is activated, the stomach produces chemicals that work on the stomach, those enteroendocrine glands. You remember G cells, we're going to review them. I mean, it's basically, oh, something's in here, and it's basically the stomach signaling to cells in the stomach, hey, we've got food coming in, get busy. And it releases a locally acting endocrine. It takes up, it almost is an autocrine, a self kind of hormone, if you want to think of it that way. It's released into the bloodstream, but it acts on itself to say, as long as there's food coming in, stay busy. And then, not a whole lot to say about the mouth. Anatomically, we said it, the tongue, not doing any of that stuff, any of this stuff, any of that stuff. That's all anatomy, don't care. Tongue, again, functionally, gripping, repositioning, saliva plays a role. All the different muscles that are there, that's fine. Taste buds, all that kind of good stuff is there. Saliva, you should know the functions. Cleanses, dissolves, moistens, and understand this is the first time we start chemical digestion. The mouth is mostly mechanical. It amylase, salivary amylase starches. That's the last time we touch starches till they get into the small intestine. So those carbs, we start breaking them down to soften them, if you want to think of it that way. And then we rely on mechanical activity and liquids to facilitate. So it's mechanical breakdown until we finally get it back into the small intestine for final processing and absorption. Most of that comes from the big three extrinsic salivary glands. You have the parotid, the huge ones that mostly make serous, mostly liquid, with a little touch of protein. Okay. The sublingual, which is mostly mucus, and they're both paired. Okay, some more protein, and the submandibular, which is again mostly serous. Those are the three big salivary glands, and yes, you have other ones that play a role, but those are the big three. Parotid, the big ones, upper cheek area. You can see the diagrams that are there: submandibular and sublingual. Here they are. Here they are from the diagram. You can see them. The parotid is much larger. Sublingual, that's the one that's mostly mucus. These are mostly serous here and serous here, etc., etc. That tells you about them. People with dry mouth, salivary function for oral health, very important. Okay, lots of problems associated. Some meds dry up. Diabetics have problems with this. AIDS patients. This is really interesting. The Sjogren syndrome. I might have mentioned it to you. He's a very wonderful tennis player. Uh, not Serena, but Venus Williams has that, and that really affected her. You would say it's not just because it's an autoimmune disorder. So when she has an acute flare, it's immunological, and that probably is the reason why she didn't win. As many Grand Slams as a lot of people thought. Again, you can see it's hypoosmotic or hypotonic, slightly acidic, but not a big deal. Electrolytes, and again, salivary amylase, and from the tongue we start fat digestion, lingual lipase. So fat digestion, we get a little bit more help in the stomach. But these, again, notice we haven't touched any proteins yet. And a variety, these are proteins not that we're dissolving. This is for mucus, lysozyme attacks bacteria, it attacks gram-positive cell wall, peptidoglycan, IgA and general defense we just went over. We get rid of some waste products in it as well, defensins, etc., etc. So all of those things. You can see that's for 1.5 liters a day. Parasympathetic dominates for that. We have salivary nuclei. We went over these. Again, in anatomy, this is the parasympathetic function of the 7th and 9th cranial nerves. 3rd cranial nerve is mostly eye. 10th cranial nerve is mostly vagus. And then everything else is teeth. And teeth, and don't do teeth, 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 won't do teeth. Teeth, 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 and teeth. Voila. Plenty for now. That's your supplemental lecture. I hope you enjoyed it as much as I enjoyed telling you about it. Bye bye.